we scan prostate cancer patients perhaps a little bit different than we do it for different solid tumors. Because we have a good biomarker, which is PSA, and also clinical symptoms, but I would argue PSA rises, or PSA rising precedes development of new disease in the scans and development of new clinical symptoms. We usually don't scan patients every 3 months, as we usually see, to monitor treatments in other cancers. Now, when we don't use PSA, or when PSA is not that reliable, I would argue that we should think about, scanning patients more often than waiting for, for new symptoms. For example, the reason why I'm stating that is because from the Helsinki data, we know that PSA is not the best biomarker, or even alkaline phosphatase. So in other words, we shouldn't be using a blood test to dictate whether or not we will complete treatment with radium-223. So I still scan patients on radium-223 probably while they're on treatment once. So, so I get baseline scans, and then perhaps after 3-4 cycles with radium-223 and at the end. The reason why I do that is because I want to know, I want to have an updated evaluation of that patient with scanning. If I happen, because the patient is doing great, and I happen not to scan him in the middle of the 6 cycles of treatment, I will do it after 6 cycles of treatment, so that I have a new updated baseline, if you will. For those of us who treat prostate cancer, we do say this every day. Metastatic prostate cancer is not a sprint; it's a marathon. So we do have a number of systemic treatments available. That number is not unlimited, though. So our goal is to, number one, to make sure the patient does not develop symptoms from the disease. Or if he does have them, we'll be able to actually improve quality of life. Number two, we want to improve overall survival of these patients. And number three, we want to do that by squeezing the effect of each line of treatment as much as we can. We have a number of treatments that are able to do that. We start having data available suggesting that a combination of treatments might be helpful, but in other times it's not that helpful. And the example of that is radium-223 as monotherapy is a good treatment option. Barata as a single therapy is a good systemic option. Combining both is not a good idea, and that's based on the radium-223 trial. So we're starting to learn that the fact that we have A, B, C, D, etc. Treatments available doesn't mean that A plus B is better than A or B alone. So as we go further, we are excited to see how studies with novel treatments reads out, as well as combinatorial options such as enzalutamide and radium-223 readouts. And the next question is, if these studies are positive, how is that going to impact how we treat patients today, and how is it going to impact the optimal sequencing that we're going to have available for our patients?